Hi, and welcome, and thank you for joining us today. My name is Stephen Kopechka, and I'm the Senior Media Strategist at Resolve to Save Lives, an initiative of Vital Strategies. Vital Strategies is a global health organization that works with governments and civil society around the world with a vision that every person be protected by a strong public health system. Our speakers for today's briefing are Dr. Tom Frieden, President and CEO of Resolve to Save Lives, an initiative of Vital Strategies, Dr. Georges Benjamin, Executive Director, American Public Health Association, Dr. Stephanie Mayfield, Director of the US COVID-19 Response Team at Resolve to Save Lives, and Justine Lendiger, Senior Advisor for Vaccines at Resolve. For those of us joining on Zoom, please note, we will use the question and answer function at the bottom of your screen for questions today. If you have a question during the remarks, please enter it in the Q&A box. For those on the phone, you can send your questions via email to press@vitalstrategies.org. I'll be back after the remarks to facilitate the question and answer session. We'll make every effort to answer as many questions as we can get to today before the briefing ends. And with that, I will hand it over to Dr. Tom Frieden.
Good morning, everyone, and thank you for joining us. In the past year, COVID became a global pandemic, killing more than 2 million people in the most disruptive health event of the century, in fact, of the past 100 years. But also in the past year, there was unprecedented scientific progress that led to the creation, testing, and validation of multiple vaccines that are both safe and effective. That's remarkable progress against a formidable enemy, the SARS-CoV-2 virus. But vaccines don't save lives. Vaccination programs save lives. Well-implemented vaccination programs can help end the COVID pandemic in this country and globally, saving hundreds of thousands of lives in the US and millions of lives around the world. But to be implemented well, vaccination programs need to use and transparently share information. What is measured can get managed, and doing that can maximize speed, safety, and equity. The report we're releasing today, COVID-19 Vaccine Indicators, recommends 6 indicators that will help health departments and communities reach all segments of the population, particularly Black and Latinx communities that are being hardest hit by the virus, but as we learned from data released yesterday by the CDC, are lagging in access to vaccination. States, local health departments, and the CDC have published initial data on vaccine rollout. Over the past week, our experts at Resolve reviewed state information and found large and important gaps in data and inconsistencies among states. Only 21 of 46 dashboards included stratified data on vaccine coverage by race and ethnicity, data that's essential in the assessment of equity in vaccine distribution, particularly among historically marginalized groups. And although 46 states reported some information on vaccine coverage, only 10 reported the percentage of population that had been fully vaccinated. Cohesive and consistent indicators across the local, state, and federal levels are necessary to address and improve vaccine uptake. Now, if you look at the slide, you'll see 6 indicators of vaccine coverage and efficacy: the phase, the number, the percentage administered, beginning and completing, and particularly the proportion by race ethnicity that have been fully vaccinated, and the proportion in long-term care facilities. There is no reason that the public shouldn't be able to know what proportion of residents and staff at every long-term health facility in the country have been vaccinated. We would want that for our relative or loved one, and that's going to help as we understand where we are with the pandemic and how we're reducing the burden. The vaccine indicators were reviewed and endorsed by leading public health organizations, including the Johns Hopkins Center for Health Security, the American Public Health Association. I'm delighted to be joined by my friend Georges Benjamin, Dr. Benjamin, the Trust for America's Health, and the Association of Schools and Programs of Public Health. It's really important to use consistent terminology and have publicly available data that can help optimize the vaccination progress and inform people on where and how to get vaccinated and on how safe their communities are. With global spread in cases and new variants continuing to emerge, Quick and effective vaccination is critical, and standardized indicators at every level will help optimize the pace, protection, and parity of vaccine rollout. We hope the federal government and states will include these indicators on their dashboards so that there's a more consistent, clear, and transparent set of data about vaccine rollout, including progress on improving equity. Now I'd like to hand the floor over to Dr. Georges Benjamin of the American Public Health Association.
Hello, everyone. Thank you, Dr. Frieden. Let me just point out that how important it is for us to do this vaccination equitably. And I'm very much interested in how we actually get from getting the vaccine delivered to actually getting shots in the arm and doing so in an equitable manner. It's going to be very important that we use all the tools in our tool shed. Public health has a long history on how to do that. That includes using mobile vans. That includes recognizing that if you use online appointment systems, that you're going to leave out people that don't have access to internet. If you don't go into the communities where people live that are disproportionately minority, those individuals are going to have challenges. You put the vaccination sites, places that are difficult to get to, that's going to be a real challenge. Having vaccination available 24 hours a day, 7 days a week, those things are also very important, particularly for shift workers. People who have to work a couple shifts a day or work odd hours are going to be important. I've often said that if we can get fast food delivered 24 hours a day, we ought to be able to get vaccinations delivered 24 hours a day, 7 days a week. The hesitancy issue is a big one for us. And as we think about hesitancy, it's important that we understand that we haven't really done a good job, even in this first phase, when we look at even healthcare workers, particularly in nursing homes, in educating those workers, many of whom have not had the type of health background or knowledge, and fundamentally come to those jobs with mistrust, particularly some of our nursing aides and our licensed practical nurses, and some of the food service workers in some of these facilities. So we need to spend a lot more time dealing with the hesitancy of those in communities, and then providing a range of wraparound supports, whether that's transportation or, again, as I mentioned, hours, and providing them the support that they need to actually get in and get the shot. The CDC pointed out how dire this was, in the first month in which they tracked vaccinations. The biggest issue was the fact that, as Dr. Frieden pointed out, data is important. Well, they did not get the data, so we really don't have a good understanding of this disparities that are existing. The CDC report pointed out that for African Americans, for example, about 5.4% of the people that got their shots were African Americans, when the population is around 12 or 13% African American. Latinx was 11.5% when the population is 18%. So we have a lot of work to do in this area to try to achieve health equity. And I would just encourage all of us to try to standardize this data, because as Tom pointed out, what gets measured gets done. Also, if you give yourself a strong and reliable target, you're able to track what's going on. So with that, let me turn it over to Dr. Stephanie Mayfield.
Thank you, Dr. Benjamin. Our states are on the front lines in getting the COVID-19 vaccines into people's arms. Meaningful and usable information are essential to successfully manage public expectations and reach all communities, particularly those that are historically marginalized and have a disproportionate burden of COVID-19. Mapping for vaccine uptake within jurisdictions and among demographic groups is needed to help ensure there is a focused, analytical, practical, and equitable approach to distributing and administering the vaccinations. Many of the state and local health departments we support are partnering with established community leaders and coalitions, such as the NAACP Links Incorporated, the National Council of Negro Women, and the Immigrant Welcome Center to promote COVID-19 vaccination awareness and deliver critical vaccine information. They are leveraging events like food drives, given the food access challenges households have encountered since the pandemic, to reach key groups. Greater data on vaccine uptake can support these efforts by helping jurisdictions identify community needs and tailor their education and outreach activities to the populations that need them most. When I served as the state of Kentucky's health commissioner during the rollout of the ACA, we used jurisdictional data to identify the segments of the population requiring greater awareness and understanding of the new healthcare law and the most effective ways to reach them. This informed our development of a comprehensive, highly targeted communication plan. That plan ultimately led to Kentucky being recognized as the state with the most successful ACA rollout. This type of data-driven approach is needed to better understand and address the current vaccine distribution effort and the nuances surrounding vaccine administration. It will help us uncover the most effective ways to get vaccines into the people's arms as quickly as possible and reduce COVID-19 related hospitalizations and deaths. Now, I would like to turn your attention to my colleague, Justine, who will provide an overview of our recommended vaccine indicators. Justine.
Hello, everyone, and thank you, Dr. Mayfield. So our 6 vaccine indicators cut across 3 domains, specifically the phase of vaccine rollout, vaccine supply, and vaccination coverage. These indicators, as was mentioned previously, supplement our previously recommended 15 essential indicators to control COVID-19. So diving right in, first we have the phase of vaccine rollout. And the one indicator in this section is really quite simple. It prompts states to indicate the current phase of vaccination, including who is eligible to be vaccinated now. As of the writing of this report, only 9 states actually display this information within their dashboards. A good example is Arkansas. On their dashboard, they clearly display that they are in phase 1B, meaning that people over 70 and education workers are eligible to receive vaccine. In order to reduce confusion, it is particularly important for states to clearly present the current phase and eligibility for the state and for each county if counties are operating in different phases or with different eligibility sequencing. The second domain looks at vaccine supply. The first recommended indicator here is the number of vaccine regimens distributed to the state per person, with a target of greater or equal to 0.8. We use the word regimens here rather than doses in anticipation that a single dose vaccine may soon be authorized. For the currently authorized mRNA vaccines, a regimen requires 2 doses for full vaccination. This is an important indicator of local vaccine supply, and looking at trends over time will help determine when states can move on to subsequent phases. And therefore, we recommend that tracking this per week as supply is distributed to states would be very beneficial. The second indicator in the supply domain is percentage of the population that could be fully vaccinated with a vaccine distributed. This target here is greater or equal to 80%. This is a key data element as it identifies the maximum upper bound for vaccination coverage with cumulative amount of vaccine that has been supplied and distributed to the state. Finally, the third indicator under supply is percentage of doses administered with a target of greater or equal to 80%. In short, this is, are the available shots getting into arms? We also recommend states that states consider tracking the percentage of doses administered within 7 days of distribution as an important indicator of the speed of vaccine rollout. 30 states and Washington, D.C. included at least one supply indicator. It's important for me to point out a key finding related to terminology. There was a great deal of variation across the states. States reported on the number of doses allocated, delivered, distributed, ordered, promised, received, requested, shipped. Sometimes the same terms were used with different meanings, while some states used multiple terms interchangeably to describe a single indicator. As you can imagine, this made it quite difficult to compare vaccine supply across states. The use of clear, consistent language reduces confusion and should be recommended at the federal level and then cascaded to states and local health departments accordingly. 2 best practices to highlight include Massachusetts, which was the only state we found publishing the percentage of its population that could be vaccinated with doses distributed. They also present this in a map by county, as well as Minnesota, which added the element of speed and reported the percentage of doses administered within 3 and 7 days of distribution. As vaccine supplies increase and with new vaccines likely to enter the market, states should be transparent with the public about how many vaccine regimens have arrived in the state, what proportion of the population that supply can cover. And because a speedy and efficient vaccine rollout is essential to save lives, states should also report what percentage of doses distributed have already been administered and how quickly. So moving on to the final domain, coverage. This is really the ultimate indicator of a successful vaccination campaign. Here we recommend 2 indicators, namely the percentage of the population partially vaccinated, i.e. the people who have started vaccination if receiving a 2-dose regimen but have not yet completed, and the percentage of the population fully vaccinated, or those who have completed the regimen or received a single-dose vaccine. The target here is greater or equal to 80%. Tracking vaccination coverage signals the level of protection against COVID-19 in a specific population, community, county, state, all the way to the national level. It also helps us consider when we may be able to relax other public health and social measures. Our research shows that 46 dashboards, in fact, all those that were existing at the time of writing this report, included at least 1 coverage indicator. This is great. However, the variety of ways in which these data were reported made it quite difficult to compare progress across states. Another key recommendation I want to underscore from the report is that it is not sufficient, as has been noted by my colleagues, it is not sufficient to report coverage as a single population figure. Stratifying by age, sex, race, ethnicity, county, prioritized populations, such as the residents and staff of long-term care facilities, is highly recommended. 33 states included data on cumulative vaccination coverage. 26 states included data stratified by age. Only 21 included data stratified by race and ethnicity. Stratified estimates of vaccination coverage, including trends over time, are crucial to provide transparency about who has received the vaccine. This data will help ensure that all groups have access to vaccine and can help states and communities better target vaccination campaigns to specific subgroups and prioritize populations as needed. I want to give a quick shout out for Ohio's dashboard. They show the percentage of people partially and fully vaccinated by race, ethnicity, age, and sex, statewide and within each county. And a shout out for New York, who is reporting the percentage of long-term care facility residents and staff who have been vaccinated statewide and by region. So in conclusion, state and local health departments should be applauded for quickly standing up COVID-19 vaccine dashboards. Overall, we were very pleased to find that the vast majority, 46 states, already have vaccine data displayed on their COVID-19 websites. These initial data are a great step in the right direction, but the limitations reduce overall usefulness and constrain states and individuals' communities' ability to use the data to maximize speed and equity. As we anticipate accelerated vaccination efforts nationally, states must quickly improve dashboards to increase standardization and really move from what is easy to count to what is most meaningful and important. Refining dashboards to track recommended indicators now may help states be more prepared as they expand vaccination to the general public. States should integrate vaccine indicators with other COVID-19 data to avoid siloed information. We also encourage states to use our recommended terminology to shift to a clear and consistent approach to reporting by vaccine phase, supply, and coverage. We hope that this report can help states prepare new or improved dashboards to provide the most meaningful and usable information to the public and public health entities. Finally, I want to thank the whole team that helped pull this supplemental report together, particularly Sydney Jones, who led this work. We're happy to take your questions. I'll turn it over to Stephen.
Thanks, Justine, and thanks to all of our speakers. We'll now begin today's question and answer portion of the briefing. As a reminder, we'll be using the Q&A function at the bottom of your screen for questions today. We'll make every effort to answer as many as we can get to today before the briefing ends. And for our first question, it comes from Sherry Rudvansky from Indy Star. Is there one way to gauge which approach is best? And can you see any patterns in efficacy when it comes to broader or narrower eligibility? In other words, are those states which have more limited pool of eligible pool doing a better or worse job at distributing doses they have in an equitable fashion than states like New York, which have many more people eligible?
Maybe I'll start and ask Dr. Benjamin, Dr. Mayfield, and Justine Landiger to comment further. I think, first off, one of the things that is problematic is that some states are holding back a second dose in the freezer rather than anticipating that there will be further supply. And I think that's one of the things that accounts for a very large difference between, according to CDC data, 46% of all vaccines that have been delivered to the state administered, and 86% between the lowest and the highest performing states. So one key approach is to get the logistics right. So you're anticipating that you're going to have new vaccine coming in, and you're not reserving in the freezer doses for some people. Better to have those doses in arms than in freezers. And then on the issue of eligibility criteria, I think what we're learning is simplicity is best. So it's really important to be clear with people about simplicity. And then the final point I'd like to make is there is a little bit of tension between numbers and equity. If you want lots of people vaccinated, you make it first come, first serve. If you want to reach the people who need it most, you need to be more targeted and to reach out to different communities. Dr. Benjamin?
Yes, I would add to that it's all in the planning. And to the extent that you want to make sure that you get the people that are most in need first, you have to write a plan that focuses on people that are most in need first, and then put around all the tools that are necessary to allow them to get there quickly, simply, easily, and at the time in which they're available to get their vaccination. And in some of these situations we saw in some of the healthcare workers initially, they're not against getting vaccinated. They simply didn't want to be first. And so now we have to make sure we have a process that cycles back to those individuals to offer them a second and maybe a third opportunity to get vaccinated. In other words, don't assume that because someone said no the first time means that they're not going to say yes the second time.
Yes, and I'll add to this that communication is absolutely essential on how you're going to notify when there's available vaccine and to what particular demographic group is now eligible. And then when there is extra vaccine, once you've, for instance, healthcare workers in a small community, you have vaccinated those. How are you communicating who's next in line? And who's next in line? Are you looking at the barriers of them being able to get to the site to efficiently get their vaccines? Some of the things we're hearing is that we have people showing up day after day after day and leaving without a vaccination. This is not an efficient vaccine process. So we're hoping that these indicators, particularly knowing how much vaccine is available for a particular population per capita, and outlining how it's going to be distributed down to the jurisdiction level, monitoring this and taking into account the equity that's needed to ensure those that are not able to get to the facility will also have other options of getting their vaccines.
Yeah, and just to underline what colleagues have said, I mean, I think I sound like a broken record here, but really we need the data. So to be able to know whether these approaches are working and to be able to identify and lift up what strategy is most successful, we need to have that stratified data. And so that can also help make sure that the groups who have been initially hesitant are reached, or who have initially have access barriers are reached. So underlining the importance of stratified data.
Thank you. Our next question comes from Mike Orskes. Is it striking? Let me just get the right. Listening to public officials, would you think the vaccine supply was still a core issue? But listening to the presentation, the emphasis is much more speeds and arms. What's your feeling on scarcity? And Dr. Frieden, would you like to take that one?
I'll start and then turn it over to colleagues. I do think scarcity is an overwhelming issue for states. Part of the reason they're holding back is that they don't have enough. Currently, the demand for vaccines is enormously higher than the supply. And while that supply will get better, it's probably not going to get much better for another month or two or more. And because of that, programs are having to juggle. That's why actually the first indicators that we're recommending are specifically that issue. How much vaccine would be available to the whole population? What's the potential regimens available? And with that, I think you can see the impact of scarcity on availability. Because until there's ample vaccine supply, it's going to be a challenging process. Dr. Benjamin, would you like to add to that?
Yes, I would add to it that the single most important thing that in my mind that the administration has done so far is design a system to give people a reliable indication about how much vaccine they're going to get for 3 weeks. You cannot plan if you don't know what your supply line is going to be. And so that's a very, very important thing that they've done. And I would certainly encourage them as the vaccine supplies continues to increase, that they continue to create and ensure a reliable, dependable supply line. Because once you've done that, then you don't have to ask people to come in and cancel appointments. You don't have to ask people to come in and leave very disappointed. And I think that's been one of the challenges that we've had so far with this. And it's not just been for the average citizen. It's been for academic health centers. It's been physicians, it's nurses. The priority population that we had in 1A and 1B, they simply weren't able to predict what they were going to have on hand. And you can't run any kind of vaccination program that way.
I just want to add one other thing, which is there's not enough currently to reach out to primary care doctors. And this is something that needs to change. Primary care doctors, community health centers, which are now being reached, are really important because that's where people can be reached where they are. Even the primary care doctors themselves often can't readily get vaccine unless they're associated with a major medical center. So addressing the primary healthcare system is very important. The person who's going to be best at convincing someone who may be reluctant to get a vaccine is their doctor.
Thank you. Our next question comes from April Simpson from the Center for Public Integrity. People of color are underrepresented in the 65 plus population, but disproportionately affected by COVID. How should demographics of senior population inform the vaccine rollout?
Dr. Benjamin, do you want to start?
Absolutely. I think that what we've learned from the senior population should help us understand that these disparities exist, and we should learn from the things that have not gone well. Meaning that online registration systems are not the ideal way to get to populations that are more at risk, i.e., communities of color. That we need to make sure that we upfront deal with the hesitancy. So, for example, when we go into a nursing home, showing up and vaccinating the residents is one thing that live there, but vaccinating the staff is a very different phenomenon. And what you probably need to do is go in on Monday and give them the educational idea of what this vaccine is. Tell them what the vaccine is. Give them the knowledge and the science so that they can have an informed decision, and then come back on Friday and vaccinate them. Now, when we're dealing with the general public, the hesitancy that we have seen in healthcare workers in long-term care facilities is very much like what we're going to see in the community. And it's probably not necessarily age dependent. We also know that, of course, very young men and women of color need to have a lot of different influencers. We need to talk to trusted influencers to talk with them. That means social media, that means radio, that means TV. That means letting people get a better understanding of the science of the vaccine. Because what people want to know is that it is safe. They also want to know it's effective. I think we've made that argument pretty successfully, but they really want to make sure that it's safe. And so that requires a different kind of conversation that has not yet been held on a large scale basis. Dr. Mayfield? You're muted.
Thank you. I'd like to add to that, the transportation is also an issue. What we're hearing from some of our jurisdictions is that, of course, everyone above 70, 65, they're not in a long-term care facility. Many people are at home, but the transportation to go and get the vaccine becomes a major issue. So trying to address that, do you get mobile vaccine clinics to neighborhoods? There are many thoughts underway right now on how we're going to address this issue of transportation once people are notified that they are eligible to get the vaccine.
Yeah, just on the data side, I would just add that what we presented today was really the basics of what should be on a public facing dashboard. And we're thinking ahead. So just to call back on that last question. But in terms of the equity, even amongst older groups, it's important as well for states and local jurisdictions to be monitoring vaccine confidence and acceptability, particularly among historically marginalized populations, internally and ongoing. And so that information to be able to have the data and then tailor strategies, as Dr. Benjamin and Dr. Mayfield talked about, and tailor communications is very, very important. So it's an important thing for states and local jurisdictions to be tracking, whether they put it on a public facing dashboard or not.
And just to wrap up on this question, 2 points to make. One is that there are long-term care facilities that have larger or smaller populations of Black and Latinx people. By having a list, as we found for New York, for some areas, at least by region, but preferably actually by facility, you'd be able to know which facilities are lagging and then provide additional support so you can get the vaccination rate up for the residents and the staff. And second, for frontline essential workers, it's very important that there are specific plans in each jurisdiction to reach out to these individuals, because they consist of people who have an increased risk of exposure to COVID, and in many cases also an increased risk of severe illness from COVID because of underlying conditions such as diabetes. Stephen, we can go on to the next question.
Thank you. Our next question comes from Hillary Burek from Business Insider. I'm going to unmute you and you can go ahead with your question.
Yeah, can you hear me all right?
We can.
Great. I just wanted to ask about a little more about how states can promote equity with extra doses. It seems like there's often kind of like a mad dash to hand those off to whoever's eligible and around at the end of a day or a week, you know, whether that's teachers or people over 65. And I'm wondering, you know, that's better than throwing extra doses in the trash, but it doesn't seem like the fairest way to have a wait list. And I'm wondering if you have any thoughts on improving that.
Well, clearly you can have the waiting list of people in your priority population and tee them up early so that you just don't have to do frankly, just a big cattle call. But if you have a list of 5-10 people that live close by that you can call into the pharmacy and they have their phone numbers. You know, doctors' offices do this all the time. Dentist offices do this all the time with their established patients, you know, and they call them up. And sometimes you know that someone's not going to show. The other thing you can do is you can't overbook, although that does tend to be a challenge, but nobody should have to come back twice to get vaccinated. No, I should say nobody should have to come back 3 times to get vaccinated. You come in and you have to get rescheduled because you run out of vaccine, that's one thing, but you ought to be able to call somebody in if you have extra vaccine. That shouldn't be such a big deal.
Justine, do you have anything you want to add about best practices on avoiding any wastage? We know that some countries are wasting fewer than 1 in 10,000 doses, and it's precious.
It is precious. And so, I mean, I agree with Dr. Benjamin and we've seen the local jurisdictions and partners that we're working with have come up with sort of waitlist solutions. At Resolve, our tech team is looking into some best practices and potential digital solutions that might facilitate going from sort of the master list of people on a waiting list for appointments or those with appointments and getting people in to get those doses. I think the key goes back to this idea of micro planning. If you are using these indicators around supply, and you have, as Dr. Benjamin mentioned, now with the administration, at least a 3-week forecast, knowing what you're going to, what supply you're going to get, so you can better plan. You do the right micro planning down to, the number of doses. What does that mean? How many people? How many vaccinators do you need? How many, down to the number of alcohol swabs that you'll need? It really is a micro plan. We've seen this work globally quite well to reduce wastage a great deal. And so I know that jurisdictions are going back to basics and going back to this idea of micro planning with the supply. Now they have a better idea of the forecast that they're getting. They'll be able to minimize this.
Thank you. And our next question comes from Stephanie Inns from the Arizona Republic. In Arizona, we have residents complaining about winter visitors taking their vaccines by getting vaccinated here. Is it equitable to have winter visitors and possibly vaccine tourists over the age of 65 get vaccinated in states where they are not permanent residents?
Well, I'll start and turn it over to the other panelists. A person is a person, and over 65 is at higher risk. So I would say, although we do our healthcare by state, not only within the US, but globally, we really have to reduce differences between areas. Now, you would hope that someone would be able to get vaccinated and certainly wouldn't travel to get vaccinated, but you'd really want the criteria to be as consistent across the country as possible, and also for performance to be as consistent as possible. And this gets into a broader issue. With vaccination, we have our strongest tool against COVID, but it's not going to kick in for many months. And so we need to double down on masking and indoor closures and minimizing sharing air indoors with people not in your household. At the same time, as vaccination scales up, cases come down, we're going to need to do better tamping down transmission, because uncontrolled transmission anywhere is a risk everywhere. We can see more resistant mutant virus strains that may evade vaccination or may evade natural immunity. And the more we reduce the number of outbreaks and clusters, we reduce viruses, we reduce the risk of more dangerous variants, not only in the US, but globally as well. So it's really in all of our interest to increase vaccination throughout the US and throughout the world. And we have much further to go to address that equity issue. Dr. Benjamin.
Yes, I think we shouldn't think of this as an equity issue. I think we should focus on, we know we're going to get everybody vaccinated. And as long as we're within the priority population, I'm not quite sure what difference it makes. Remember that if somebody is coming to a warm weather state for the winter, they're going to be there. And therefore, they run the risk of getting infected or infecting someone else. So we want them to be vaccinated. Now, I'm not trying to encourage vaccine tourism. I'm not asking anyone to hop on a plane, go someplace so they can get vaccinated, hop back on the plane and go home. That's not what we're talking about. But also remind yourself that we have regional issues. So I'm in the Washington, D.C. metropolitan region, and we have many people who work in D.C. but live in Maryland. They got vaccinated in the District of Columbia. And so the governors and the mayor, DC, Maryland, and Virginia, have a vaccine sharing plan where they're trying to augment the vaccination, doses in the District of Columbia, recognizing that many of the residents of those two states actually work in the district and got vaccinated in the district. But you also have to remind yourself that they're providing a service where they live. So it is complicated. And I think the simpler we make this, the more functional this will be. So for me, let people get vaccinated where they are, as long as they're in the priority population.
Thank you. And that's all the questions we have. Back to Dr. Frieden for closing remarks.
Thank you very much. In the race between vaccinations and the spread of the virus, information to track the effectiveness of the vaccination program is critical. This is a tough virus to fight. It outnumbers us, and we have to outsmart it. These indicators will help us improve our vaccine response and provide transparency on rollout. We have to continue to double down on protection protocols. Mask up, watch your distance, minimize sharing indoor air with people outside your household. As vaccines scale up and cases come down, we'll need to do a much better job on testing, tracing, isolation, and quarantine. Because as I said earlier, uncontrolled spread anywhere gives our collective enemy, the virus, the opportunity to further evolve and evade our defenses. Thank you very much for joining us. Thanks to the team for terrific work on yet another report. Thanks to our partners for joining us and contributing to both the content of the report and its release and dissemination. Back to Stephen.
And thank you for joining us today. We will send materials discussed in the briefing along with a recording and transcript very soon. For any follow-up questions, please email press@vitalstrategies.org. And again, thank you for joining us today.